Wonderful. Thank you so much. I'm really honored to be here presenting today on a really interesting topic to all of us these days, calling it Tele-Geri, telehealth with respect to geriatrics patients, building blocks to successful video visit with your older adult patients. You will notice, as is my nature, I'm going to be talking with a lot of hope and positivity and lots of silver linings, but I do recognize that this is a hard time for everyone in the realm of both the way we are delivering care and the way we're living our lives. And without further ado, Kate's already having trouble. There we go. Told you a little bit about who I am. I spent 8 years after my geriatric medicine fellowship practicing at Carolyn Downs Family Medical Center, a federally qualified health center here in the central area of Seattle. And then 5 years being a full-fledged clinician educator here at Swedish on the family medicine faculty and directing the geriatrics fellowship. As Kate mentioned, I have an interest in interprofessional education and the geriatrics workforce, and a 2-month now history of newfound interest in telehealth related to older adults. You can see here that a picture of my Geri team, Sarah Babineau, my co-faculty, Nadine playing the guitar there, one of our fellows, and Phyllis eating the ice cream. She's the only one eating ice cream at our ice cream Zoom party. And I bring this up because Zoom has kind of taken over our lives. It happens to be the platform in which we deliver telehealth, but it has taken over our lives personally and professionally. And even though we may have some Zoom fatigue, this picture is a little bit about our Zoom joy and finding ways to connect with one another. Hopefully in the next 15 minutes or so, I will demonstrate how telemedicine has been an essential aspect of our COVID response for the care of older adults. I'll share with you a framework with which you can approach your video visits with geriatric specific considerations. I'll highlight the 4Ms and how they can help us provide excellent tele-geri care, and I'll emphasize issues of access and equity when thinking about the future of telemedicine in geriatrics. And so we need to figure out our terms here and our definitions, and like many things, it's a kind of a complex and confusing thing. The man down below is Sanjeev Arora. He is the actual founder of ECHO, Project ECHO. Without him, we would not be here today. He's a hepatologist at the University of New Mexico, and he has an interesting take on telehealth versus telemedicine. He describes telehealth as skill building and coaching providers and teams through technology, so like exactly what we're doing today, and telemedicine as reaching to patients through virtual encounters. That's not the sort of, I think, most accepted definition, but just one, and an important one because of who Sanjeev Arora is. But this talk, we're gonna be using telehealth and telemedicine pretty interchangeably. I kind of like telehealth better because it's more inclusive to other virtual care like psychology and physical therapy, for example, that can also be used from a telehealth perspective. So why are we even talking about this today? Why are we here? We are here because of COVID-19, and COVID-19 has sort of forced telehealth into our everyday lives in a way that happened quickly. And I'm going to share with you the response, our COVID response of our geriatric medicine team, which lives inside our family medicine residency program, and share with you what we've done with regards to telehealth in all of the care settings that we practice. So in the acute care hospital, like everybody, we were preparing for the surge in March, which thankfully really never came and overwhelmed us, but we had backups of backups. We had faculty ready to back up. We had fellows and residents ready to back up if they were needed. And very early on, we started inpatient televideo geriatrics consults led by one of our fellows, Nadine Audisho. We had a device that was we got donated through the Swedish Foundation and have been doing and providing inpatient televideo geriatrics consults in that setting. In the ambulatory setting, which is really what we're focusing on today, very early on, with Seattle being the early epicenter of COVID-19, we had to decide who gets seen in person, who gets seen in telehealth. And, I think first and foremost for our older adults, we made a very quick pivot to seeing almost everybody virtually and really only seeing folks face-to-face when it could potentially prevent a hospitalization or when they needed a procedure that could prevent a hospitalization. I'll get back to the next level in a minute, but in the nursing home, we early pivoted to Televideo, which we've been doing for quite a while now, pretty much exclusively. And in the home care setting, we really excitingly launched a Televideo home visit project, virtual home visit project, where we're deploying iPads to patients' homes so that if they don't have a device or the bandwidth, we are providing them with an iPad and a hotspot so that we can do virtual care. From coming back to what we're talking about today is really some of the mainstay of primary care, the chronic disease management and the ambulatory care, which we are doing telephonically, I'd say even more than on the Televideo, and also using MyChart more frequently. We are reaching out to patients, checking on basic needs. We have a grocery delivery project, free grocery delivery project, again, funded by the Swedish Foundation for our older adults. And we're also doing consults, Televideo and telephonic consults in our ambulatory interprofessional geriatric assessment clinic. But really what we're focusing on today, and I wanted to just say that I'm really proud of the work we've done. I'm proud of our team and how we've responded. And today we're really gonna focus on the Televideo visit. This is on everyone's mind, including Paula Spann in the New York Times, who published this article last week on titled "With Red Tape Lifted, Dr. Zoom Will See You Now. The pandemic pushed Medicare to make telemedicine more financially attractive, and now doctors, patients, and regulators will see if they want to stick with it." And in this article, she goes on talking a little bit about both the barriers and benefits of telehealth, which we will get into today as well. So COVID-19 has really forced us to recognize the potential of telehealth. And we found that even that telehealth may even be preferred for some patients over coming to the clinic. And that's because it can overcome geriatric specific barriers like mobility and transportation in a really pretty robust way. One of the joys for me is that it brings together a care team, especially caregivers that may live out of state, but always and importantly, we need to focus on the fact that access is a significant issue and that this resource we have may actually be widening the so-called digital divide. So I'm going to walk you through the building blocks of a Televideo visit. This comes from a tool that you all will have free access to, which I was honored to co-author. It's a geriatrics evaluation and management tool for Televideo visits, published by the American Geriatric Society. Amy will show you how you can log into that and get that tool free afterwards. But I was honored to co-author that, and that was published just a couple weeks ago. And these building blocks really come from that tool. And I'm going to walk you through these building blocks by way of telling you about a Televideo visit I had with Mrs. G. She's in this picture here in the top left corner. She is a 99-year-old pianist. She has osteoporosis, history of a hip fracture, coronary artery disease, and she lives independently in a retirement community on First Hill. So, step one of the building blocks, prepare. Preparation for these visits is even more important than your face-to-face visit because the technology can be so challenging. You want to verify the technology on your side and on the patient side and arrange for support if possible. So for Mrs. G, she had a staff member in her assisted living community that was actually able to come into her apartment and help connect on her iPad tablet. You can see here that her daughter and son-in-law from Eastern Washington joined us, and they were able to get the link for our visit because they had MyChart proxy. And then what they did was they shared that link with the staff member at the at her facility, and then we were all able to connect. Consent is very important for the telehealth visit, and that is worked right into our template and should be, if it's not already, with yours. But you need to anticipate the geriatric specific challenges. So Mrs. G has hearing aids, and she heard me pretty well, but not perfectly. And I would say in our next visit, I would recommend that she try to get some Bluetooth wireless headphones. In my personal experience as a hearing aid wearer, it makes so much difference if you can connect directly to the device either through your hearing aids, if you're lucky like me, or actually through Bluetooth headsets, so something to consider. From a visual standpoint, there are adaptations you can help your patient with if they're having trouble seeing, and hopefully there'll be more of those to come. From a cognitive standpoint, this is an issue with people who have moderate to advanced stage dementia. Mrs. G is pretty cognitively well, so this is not an issue for her, but for others, if they are advanced in their dementia, they may get confused. And so you may only want to engage with them on the video for a short period of time and then focus maybe in another room with the caregiver for the rest of the visit. And connectivity is an issue for a lot of people. I had a visit this week with an 80-year-old person and her son, who was the caregiver, and then the son's wife, the daughter-in-law, wasn't able to actually get in and do her own work while we were on the visit because they were sort of maxing out their bandwidth by talking to us. So history, always an important part of our visits. Paying attention in a very different way is important in these visits. Building rapport, especially if you've never met a person and you're having your first visit on Televideo, that's pretty tricky. For Mrs. G and I, we know each other for 5 or 6 years, so this wasn't as difficult, and actually just seeing her face and her seeing mine was really therapeutic. It's a reminder right now for me to look in my video camera, as we should during our video visits, to make sure we're making that eye contact instead of looking at our electronic record, for instance. And instead of just asking, as we would in a routine visit, history questions, the benefit of being at a patient's home is pretty dramatic. So in this picture, so instead of asking Mrs. G, what medications are you taking and how do you handle them, she actually showed me how she filled her Medisat, which was so really amazing. She then helped walk me through her apartment, and we looked for hazards, and she took me to her bathroom. We looked around her bathroom and all her adaptations, and then she stepped on the scale for me to get the weight for the visit. So that was pretty cool. As I said, her family was able to zoom in with us, and they were able to remind me that there were a couple questions Mrs. G had that she had forgotten to ask. So really, really important. From the physical exam standpoint, never ever will a televideo visit take the place of an in-person visit. Even just the touch that you are losing by being through video cannot be replaced. However, we can do inspection and observation and coach the patient to perform key elements. If possible, if the camera can move, you can have them show you their leg, push their finger on their leg, look for pitting edema, have them walk them through a musculoskeletal range of motion, palpation, etc. There are certainly limitations to the physical exam, and sometimes we need to bring people in the office, even in these settings, if we need to do a very specific physical exam maneuver. Vital signs, I found that maybe half of my patients have some home equipment like a blood pressure cuff and or a scale, but many don't. And so we need to decide if we are going to do this work, we need to decide whether we want to deliver the equipment or help patients get access to the equipment that may help us deliver better care. And there are a lot of high-tech options. Nadine, one of my fellows, is really excited about all these things, and she brings some of these aspects up to us to make us aware. And they're very cool things that we can do, including in this picture, having a device on the patient side, which allows us to hear the heart sounds and lung sounds. It remains to be seen whether this will be accessible to our patients and how it will play a role in geriatrics care at home. But there's a lot of tech out there, and you know that they are building quickly right now. So during your visit with your geriatric patient, you may need to use some specific geriatrics tools. These tools are not developed for Televideo, but many have been adapted to be used in that way. We'll link to some of these tools afterwards, but the Montreal Cognitive Assessment has a whole section on how to deliver this remotely, both telephonically and by Televideo, and we've been using that. The geriatric depression scale is a yes/no, so fairly easy 15-point scale that we use often to screen for depression. For Mrs. G, from a mobility perspective, I had her do sit to stand 30 seconds, which is a pretty standard test we do to check on strength and mobility. She scored an 8, which was well above the norm for her 99 years, which is 4. Go, Mrs. G. We look for frailty and function. We like the clinical frailty scale. And then never before than when a patient has their medications in front of you? Is it more enticing to think about deprescribing? And we like the deprescribing.org tool that you can use when you're on the phone or video with a patient. Advanced care planning is always important in our geriatrics visits, always and forever, but perhaps never more so than during a pandemic, which disproportionately affects older adults like COVID-19 in both morbidity and mortality. And there are actual real benefits of doing advanced care planning on televideo, even though there are challenges as well. But when the patient is in the comfort of their home with a caregiver present, perhaps they have the documents that they have signed and done but forget to bring to you in the office. You know, these are some considerations that may make it easier in some ways to deliver a high quality advanced care planning on televideo. If you don't know already, one of the tools we love is Prepare for Your Care. Rebecca Sidore from UCSF leads that effort, and you should take a look at it if you're not familiar with it. But she and a few others authored an article recently expressing the importance of advanced care planning in the time of COVID, highlighting 3 key elements, which are always important in advanced care planning: identifying the health proxy, asking about whether an advance directive is in place, and documenting the patient's wishes. And actually just today, another article in Annals of Internal Medicine was published highlighting very specific recommendations for doing advanced care planning on televideo. So if you're interested, you can take a look at that and learn more. So wrapping up, know your time limits, and my time limit here is coming up soon, but 40 minutes for our visits on Zoom is our time limit, and so make sure you're planning for that so you don't get cut off. Prepare your written summary, send it through the after visit summary, or put it in the mail if they don't have my chart, for instance, and schedule your follow-up. So Mrs. G, we scheduled her follow-up for 2 weeks because we had made some medication changes. And for the first time in my career, I am able to actually schedule folks for follow-up, which is extremely patient-centered. And I'm not sure I absolutely love doing it, but it's very convenient and only took a pandemic for me to figure out. So I just want to make sure that you avoid ageist assumptions that, for instance, 99-year-old Mrs. G, some might assume she wouldn't be interested in doing a televideo visit, but she was. We must consider equity and access. So Derek Feely, the CEO of the Institute of Health Improvement, says, it's up to each one of us to make decisions and take actions that will determine whether our new normal is more just and more equitable than our old one. We need to consider quality issues, like how do we do this well? What are our quality measures? And then always, you know, all our institutions are struggling financially, and this will be key in how televideo and telehealth plays a role in our future care. No geriatrics talk is complete without a focus on age-friendly health systems 4M's framework, which we love and which you should love too. It focuses evidence-based geriatrics care around the 4M's, leading with what matters most: mobility, mentation, and medications. And so I've listed here a 4M's approach to televideo visits, a lot of which we discussed today, but just present this framework for you to look at for a moment and consider. So hopefully I have demonstrated how telemedicine has been an essential aspect of our COVID response for the care of older adults. I've shared with you a framework with which you can approach your video visits with geriatric specific considerations. I've highlighted the 4M's and how they can help us provide excellent Tele-Geri care, and I've emphasized issues of access and equity when thinking about the future of telemedicine in geriatrics. I have a ton more fun things that I'd love to share with you, but really at this point, I'm going to stop and answer questions.